Good afternoon and welcome to Webinar Wednesday. Today we are joined by Clarity's Ty Greenhall, Industry Principal Healthcare, and Skip Sorrells, Senior Director Healthcare. Webinar Wednesday would like to thank our sponsor Clarity, formerly Mitigate by Clarity. As the world's most trusted healthcare cybersecurity company, Clarity empowers HDOs to comprehensively monitor and manage risk across their healthcare extended Internet of Things environment. Whether it be through a medical device or a building management system, attack surfaces grow as connected assets expand, creating security blind spots that pose risks to availability, integrity, and safety. Clarity tackles these risks to ensure cyber and operations resilience are within your reach. So please visit clarity.com. Just a reminder about our HTM mixer, which is being held at the Marriott Resort Griffin Gate in Lexington, Kentucky on November the 15th and 16th. Our mixers are a slightly modified, smaller, shorter duration and less crowded event than our MD Expos, but still provide valuable continuing education, networking and vendor engagement opportunities. So for more information and registration details, please visit htmmixer.com. Also, just a reminder to save the date for our spring MD Expo, which we held at the Pechanga Resort Casino in Temecula, California, April the 15th to the 17th. Join us for 3 days of education, networking, and the latest advances in medical technology products and services. For more information and registration details, please visit mdexposhow.com. Also like to say congratulations to our finalists for the second annual Tech Choice Awards. TechNation is honoured to be part of these awards that are 100% nominated by and voted by the HTM industry. All the finalists have been contacted and voting is open online through January the 10th, 2025. So please visit onetechnation.com/Tech Choice Awards to vote for all the categories. And the winners will be announced in the March issue of TechNation. Now, as usual, today's webinar is eligible for 1 CE credit from the ACI, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Let's kick off today's webinar by giving away one of our Webinar Wednesday 10th anniversary prizes. Today's prize is a $100 Amazon gift card. So using the questions feature on your dashboard, let me know the answer to the following trivia question. October is Adopt a Shelter Dog Month. What is the breed of dog that appeared in the movie Marley and Me? And just an extra clue, it's the most popular dog breed in the US. I'll reveal the answer and of course our winner at the end of the webinar. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. As I mentioned earlier, our presenters today are Ty and Skip. So Ty, you may begin whenever you're ready.
Well, thank you very much. We are absolutely delighted to be here as always. I think today we've got a very practical topic. We're going to take this topic and craft it into not only telling you what the attack vectors are, but what the government's doing about them, what that looks like from a compliance regulation perspective, and then what you can do about it and how Clarity is supporting that whole initiative. So we're really looking forward to this topic today. My name, Ty Greenhall, as you were just told, industry principal. But just a little bit of credibility here on what we're going to be talking about. I've been involved with the initiatives to develop the cybersecurity best practices under the 405D group, also with the Healthcare Sector Coordinating Council Cybersecurity Working Group for 7 or 8 years now. So, you know, as a part of that, have been involved with the research and documentation and the landscape analysis, which we're going to talk about a little bit more today, but also even with the findings, the informal surveys that go along with talking to hospitals that have been breached, and all of them fall into this pattern that we're going to discuss today. And we're going to take this information and we're going to bring it down to a rubber meets the road level for HTM and how it applies to you and what's important to you. And I thought the best person to do that with would be my new colleague, Skip Sorrells, who I think on the last time we were here was still employed with Ascension. So he's a new addition to our team. And so Skip, would you introduce yourself and tell us a little bit about what you were doing at Ascension and your new position here?
Sure. Thanks, Ty. Thanks for having me. So I spent the last 6 years at Ascension as a director of cybersecurity there, and was asked to join the team with a very particular charter, and that being building out a med device program for cybersecurity. And obviously leverage the technology of Clarity along the way, Clarity Mitigate. And the background prior to that, I actually was a clinician. I was a critical care trauma nurse for several years in the early 90s, and spent several years at Dell, which is what afforded me the introduction to Ascension and the role, and ultimately leveraging technology for the program that we built there. And I've been in this role with Clarity now for about 2.5 months, and I'm super excited to be here.
Well, we're super excited to have you, and looking forward to this presentation and you providing your insights as we go along here. What I want to start off with right out of the gate is, what are the attack vectors? So the top 3 attack vectors, the first one is social engineering or phishing. I don't think that's a surprise to anybody. And that's not only the attacks from the blanket emails that go out, but also social engineering where someone might be calling the support department and acting like they're an employee and trying to get password resets or getting their new MFA installed on their phone, or whatever they were able to do to gain access by resetting a device. There's all sorts of different ways, but that's been number one clearly for a long time. But according to the Verizon data breach investigation report that came out in 2024, it showed that there's a decline in social engineering and an increase in what we would call like direct exploits. They're targeted. It's like, I'm going to attack that hospital. And so they're looking for vulnerabilities at that hospital. And now the social engineering and the vulnerability exploits are about equal. So wouldn't be surprised to know that number 2 attack vector is attacking vulnerabilities. But in specific, they are looking for internet-facing devices with known exploitable vulnerabilities, which is a category of vulnerabilities, which we'll get into here in just a minute. And then third parties. This is third-party risk. It's epidemic. It is absolutely a problem. Kind of, how do you protect something that's really outside of your control? It becomes very difficult. So this is how they get into the system, and they get in via it's not just IT devices. It's anything connected to the internet. It's a medical device, an IoT device, a building management system. All of these devices are essentially windows or doors to the network. And so once the bad guys are in, they basically figure out a way to escalate their credentials, gain control where they can do and go anywhere they want. They install ransomware, and game's over. You're deciding whether you're going to pay ransom or not. So this all came from the landscape analysis, which is up in the right-hand corner. You can Google search that if you want, which is a combination of all sorts of surveys and threat reports and studies and questionnaires and interviews. And so, that's the first version. We're going to be creating a second version here within the next year or so. We're going to be updating that. But currently, this is where the attack vectors are coming from. So with that, you've got taking those. It's they've decided what's the government going to do about them? We need to create a set of recommendations to address them, basically stop the bleeding. And so they came out with these things called HPHCPGs, or health and public health cybersecurity performance goals. And they're now signaling they're going to become mandates. They are voluntary right now, but they've got 20 of them. The essential and then enhanced, we're going to show them all here to you in just a second. But the essentials here are designed to go along with these 3 vectors. So these 4 really kind of go with attack vector 1. These 3 go with attack vector 2, and these 3 go with attack vector 3. So 1, 2, and 3. And then you've got the enhanced goals over here. So I'm gonna pause and Skip. What are your comments with respect to the top 3 vectors and what you think about these CPGs?
So I think that obviously the numbers don't lie, and I can tell you from experience, we can relate to those type of methodologies. I think the interesting part for me in healthcare is that up until now, everything has been recommended. The government entities, those types of things going on. The Patch Act was really the first instance that I saw where some form of accountability was being placed upon an organization, and that being the med device manufacturers. And you and I talked several years back about how we anticipated there was going to be some form of regulation coming towards the healthcare providers. And fast forward to today, and we're seeing those signals. I don't think there's anything here that I would put in the category of rocket science. It's really the basic foundational aspects of cybersecurity. Many of these fall under the CIS controls, and the basic approach for each of those controls, CIS 1 being asset management, number 2, software management, 3, vulnerability management. All of those things, however, in our world today mean nothing without visibility. One of the biggest concerns that we have in cyber is not knowing what we don't know, because we don't have the opportunity to protect it.
To add to your comments there, they have not mandated yet, but again, signaling for enforcement and incentives, the carrot and the stick. They've put money in the White House budget and the budget brief for these 20 HPHCPGs. And so what they've done is they've said, breaking them up into essential, they've said, well, we want $800 million for grants and subsidies, or however they're going to dole this out. Again, none of this is in stone yet. It is proposed, it is budgeted or requested for budget, and then kind of a timeline. If you don't do them by a certain, if acute care hospitals don't do them by a certain time, then there's going to be a penalty, 100% market basket, which basically, if you just think about 2 to 4% of your Medicare income, which is crippling to a hospital. So that's up to. So huge penalties for not complying, and then also for the critical access hospitals, and then even more so going out. And then for the enhanced, 500 million and a little delay. But again, I think the timing might be moved up a little bit because the industry's so under attack here. But the point, this has all been proposed, but already, just as this in September, the Senate came out with a new proposed bill, came out of committee that had all of this in it. Everything we've talked about so far is, and more, is in this bill. They're serious as a heart attack about, we're not doing it. We keep on getting attacked over and over and over again. Hospitals are getting shut down. Mortality is being affected. Hospitals can't perform business. We're bleeding financially. And so government's going to step in and force some sort of additional attention and investment. Thoughts on that, Skip? Anything really to add on that one?
I don't think so. I mean, I think I've often wondered how long it would take until there was some form of enforcement and accountability tied to the financial aspects of healthcare. So,
yeah, from a practitioner's perspective, had you heard, or did you ever get the feel that it was almost like, I don't want to be mandated to do anything, but I'm not going to get the funding and support for the program I need until it is?
Skip's personal opinion on that is, healthcare as a whole is sorely underfunded and under-resourced when it comes to cybersecurity in the first place. So on one hand, I'm not a fan of regulation, because I think as practitioners, we should operate with the mindset of doing well, doing good, and doing no harm. But on the other hand, if it afforded the opportunity to do additional things or improve upon things we had because we had a funding source outside of our own budget, I would welcome it. So it's kind of a double-edged sword to a degree, but I do think good intentions and hopefully financial incentives will help mature the practice.
Yeah, totally agree. So kind of drilling down into the different vectors here. So again, the first one being social engineering, email security, MFA, encryption, training, pretty, like you were saying, Skip, pretty basic stuff. But just to support that, we also have done a global state of CPS security 2024 report that was just released. You can find this out on the internet. And a couple of the responses there from the survey perspective, we're missing that threat detection and response perspective on OT, operational technology. For those of you who aren't familiar with the term operational technology, it's different than IT, information technology, and OT is, in this case, medical devices, IoT, Internet of Things, building management systems, clinical IoT, things like that. So, specific to kind of integrating in with the Security Operations Center, it's just not there for all. That's just not there for IT devices. And same thing with the threat intelligence. So that's that's one that's being handled. We have a lot of attention on the social engineering perspective, but when we drill down into the attack vector 2, kind of expanding out the detail on a couple of these HPH CPGs, the mitigate known vulnerabilities, it says, reduce the likelihood of threat actors exploiting known vulnerabilities to breach organizational networks that are directly accessible from the internet. That makes, it's like, it makes sense, right? And on the other side, you've got asset inventory, where, Skip, you were saying the first thing you need to do is visibility. You got to see what you don't see. But then it's calling out unmanaged assets, which, Skip, what's the significance in your mind of unmanaged assets being called out here? And what are they?
So think of an organization where the IT infrastructure manages servers, storage, desktops, laptops, tablets. those are known and considered managed. They almost always have at least one, if not multiple, security agents installed on them. Contrast that to the unmanaged, which could be a device that's brought in as a demo device from a salesperson for a medical device company. It's plugged into the network. It doesn't have agents. It's unbeknownst to the organization and could represent a form of threat or risk, and is considered unmanaged. The same applies to any other technology that's network connected that is unknown to those within it. In healthcare, for many, many years, I've watched people bring their own devices in. We have patients that bring laptops and computers, and in the absence of network segmentation, it represents threat and risk because it's not protected by the technical controls, also known as the agents, and the visibility of other technologies in the environment. So I go back to my statement. For those things we know, we can take action. For the things we don't know exist, it's really hard to create protection and security.
Yeah. So this one specifically for me, for everybody who's HTM. So if you just kind of follow the logic, government says, hey, you got to do this. If you don't, and you got to go pay attention to your unmanaged devices now and make sure they're cyber secure, or we're going to withhold your Medicare funding, and or it may determine whether you get hundreds of thousands of dollars in support. Somebody's coming to talk to your department. It's if they don't, they're not doing it correctly. So this is going to drive attention in your direction. And again, going back to kind of just data that we have in the survey, 45% of we call it CPS, which is cyber physical systems or OT devices, all the medical devices, IoT, building management stuff we were talking about. So 45% of CPS devices are connected, and it's the number 2 vulnerability. And 66% of those organizations think that they've got insufficient risk assessments with vulnerability management. So they're well over half don't think they're doing a good enough job there. And then we recently put out a study where we looked at all the, us being best in class for 4 years in a row. We've got 10 times the amount of clients that anybody else does in the industry for good reason, but it provides us a wider view of all the devices out there under our security solution. And some of the statistics we're finding are pretty daunting, that 72% of imaging systems are connected to the internet and have at least one KEV, known exploitable vulnerability. And so there's just the statistics that we see also back up the top threat here as being expressed by the Department of Health and Human Services landscape analysis. So Skip, so explain to me what a CVSS is and why they're not all the same.
Okay, let's start with the designation of CVE. That is the identifier for a specific vulnerability. And the CVSS score is a score of how bad is the vulnerability. And in this case, we've got representation of a 7.8, which is considered a high. And in looking at that, quite frankly, there are millions of vulnerabilities out in the world today. And the question really becomes, how do you assess them, and then more importantly, prioritize your activities around the remediation of them amongst the mass of the noise of so many vulnerabilities? It's a daunting task.
Didn't you have unlimited resources over there at Ascension to just take care of all the vulnerabilities?
No, unfortunately not. And I don't have a peer in healthcare and cyber that does either. It's probably one of the biggest challenges we have. And I would tell you that we refer to it as noise. There's so much noise from the plethora of vulnerabilities that it's really hard to tune into what's important that requires action in the form of remediation or mitigation.
Yeah, and this particular one, this is by a ransomware group called Black Basta, and they have taken down many healthcare systems in the U.S. So this is just one of their exploits that they use. But why, so that one's a 7.8 on that scale. Can you tell me, describe this scale, and your thoughts on it related to that 7.8, Skip?
Sure. So if we look at the data in the diagram here on the left-hand side, we have the the National Vulnerability Database, and it's a representation of 433,000 different vulnerabilities. You then subdivide that into their severity based on that CVSS score. Further, or I should say the severity, then the score, CVSS score, and now coupled with that, we have the vertical or column there for KEV, known exploitable vulnerabilities. What's the importance of that? It's one thing to have a vulnerability. It's much worse to have one that has a known exploited vulnerability, meaning hackers are leveraging that vulnerability in the wild to compromise systems. And if the system is exposed to the internet, it heightens that risk and the opportunity for the attacker to make and take advantage of that exploitable vulnerability.
So why would you want to worry about a 7.8? Why not just take care of the 9s and 10s?
Well, I think in this reference, the importance is the coupling of the known exploited vulnerability. In other words, hackers have toolkits, and I'll go back to Black Basta. They leveraged between 7 and 8 different vulnerabilities in combination with one another to perform their attacks, and that's referred to as their TTP. It's the modus operandi of how they do things and their attacks and the strategies they use to do so. So if you understand that, and you understand that they're already exploiting vulnerabilities, and you can tie that known exploited vulnerability designation to a score, you get a little bit different prioritization. And if you look at the visualization here, I would say the top 3 CVS scores, I think we did the math, it's right around 400 known exploited vulnerabilities. And that becomes should become the focus of a vulnerability management program, or CTEM, continuous threat and exposure management program, the new buzzword for vulnerability management remediation these days. And in the absence of resources and the lack of funding, it becomes very important to be surgical in the approach to remediation mitigation. Meaning, if I got a life-threatening injury or illness in a patient, the same type of application would go to a vulnerability in the environment. We would want to go after, treat immediately those things first, and work our way down in terms of diminishing criticality.
So if you're a hacker, are you going after the 9s and 10s? Is that what?
No. That's the shift in the landscape that we're seeing. They're beginning to look into the known vulnerabilities from years past that actually are easier to compromise. And unfortunately, in healthcare, due to the legacy nature of assets and medical devices, meaning they've been around for many years, a large portion of those are end of support and end of life, meaning they're no longer patched and patches aren't available. And so a hacker operates like a thief. They're going to walk around the neighborhood and rattle the doorknob to see if the door's unlocked. They're not going to mess with busting through a window unless they're just really, opportunistic and don't really care if they get caught. So I use that analogy to say the path of least resistance is where the hackers are going to focus their efforts, because it makes it a whole lot easier to do what they do, and that is destroy environments, or ransom them, or both?
It is a wicked problem. So what we have found is that, it's not the 0-day vulnerabilities which are really causing the breaches. Only 2 to 7% of vulnerabilities are actually exploited. So out of all those, I think what, 444,000 CVEs, there's only a few, right? So being able to determine what they are, but not just that, not just which ones are being exploited, but taking a broader look to include business outcomes. And this is where we're kind of separating the older vulnerability management approaches to the new vulnerability management approaches, as people and organizations are getting data, more comprehensive data from systems like ours, where they're saying, why am I running my business operations this way? How does managing risk impact my business? How does my business impact risk? So we're having to integrate all of this together, and that's best represented, we think, in a model called it's called exposure management, and it's built into our workflow and functionality. But basically, it's the ability to say, okay, instead of trying to boil the ocean, we're going to say, let's take a look at the scope. Let's whether it's for a certain hospital, we want to look at the vulnerabilities, or a device type, or a department, then find them all, which is much more difficult than it sounds. We have a way we call deep packet inspection that we do that. It's much more detail. It produces much more detail, harder to do. We've invested more in it, but like Skip said, if you can't see it, you can't protect it. But you also get the data out of the device, very granular data for other things that we'll show you in just a minute, but then also the communications of the device. What is it talking to? What should it be talking to? And then when you get into the prioritization component, again, what's the business impact? What is this? Is this device in, all the devices in an ICU, or are you looking at devices and this one is in an ICU and this one is over in a clinic that isn't really used all that much? So, one device becomes more of a priority than another. But and then again, based on, is it internet facing? Is it exploitable? Is it got a KEV? There's a lot of different variables in this. Then you got to validate with the manufacturer, and then the mobilization. So it's like an action on it. Like what are you going to do from a mitigation perspective? Is it network segmentation? Is it a firewall? Is it changing a password? Is it stopping the use of an insecure protocol? What is it that you need to do there? So that's, with that said, that's how we suggest managing the ability to find. We can find all the devices that are internet facing, and then also the ones with KEV. So we can actually help with your limited resources in knowing what to go for. Can you kind of walk us through this slide or this report and how you would use it, Skip?
Sure.
Or what it says to you?
Yeah, absolutely. So it moves from left to right, just like the diagram previously. Starts out with a vulnerability name and moves to the right where you see the CVSS score. And then the middle column is representation of whether it's actively exploited. And then there's a representation of known exploits, and unfortunately there can be more than one associated to an asset, meaning multiple vulnerabilities with multiple KEVs. And then to the far right, we have a grouping. It's the prioritization that we recommend is taken based on our view and detail of the overall exposure, the level of risk, and the KEVs. And so we're able to group those assets to say, hey, this is priority one. You need to really go focus on this, and then follow it in order of progression to the least risk.
Awesome. So that's number 2. So 3, third parties. Identify, assess, and mitigate risks associated with third-party products and services. And if you go search HPH CPGs, I think it's under ASPR. ASPR is the department now that's managing it all. You can find all these and expand and collapse each one of the 20 HPH CPGs to get more information if you'd like. But so now we're talking about this accessing third parties having access. And I guess, again, our latest report out there that 82% of the respondents had attacks originating from third parties, 45% over 5 times. And well over half have no understanding, or they're at least concerned about their medical devices, MDMs, the medical device manufacturers having access, and then not being able to restrict down to a subsystem level for control. So people come in and they just, they're kind of opened up for all sorts of mischief if they're not being controlled on what devices they can actually go to, where they can't go to. And then the VPNs, I think, is everybody, not everybody, but I'll just tell you, VPNs are not the most secure. All right, so Skip, your thoughts on, I mean, any one of these statistics, is this shocking to you from a provider's perspective?
No, it's not shocking, and I can tell you from experience that it wasn't shocking, but it was eye-opening to really understand the number of remote access tools that you would find in a healthcare organization. I think part of this same report, we call out that 44% of the healthcare organizations we do business with have 6 or more remote access tools in use in their environment. So the question becomes, based on these statistics, do they know about them all? Do they know who's using them, for what purpose? And more importantly, how secure or insecure are they? And I would lean towards it's probably less secure than you think, and probably not patched or updated, and just comes with a whole mess of challenges to overcome.
So we have just released a solution to this. We've had it, Clarity purchased Mitigate a while ago, and Clarity had a solution for this for the manufacturing industrial environment. And so we've just applied it to, rewrote it and applied it to healthcare. Can you talk a little bit about, what we're doing there, Skip, and what the benefits are?
So I think the platform itself is a first step in the direction of consolidating the remote access tools of third parties. So it gives you the ability to centralize their access, to monitor it, to quite frankly record it. So if you look at the HIPAA regulations with regard to exposure to PHI, the level of archiving of logs that you have to maintain for multiple years, all the things that go in to meet the requirements of HIPAA, that's now available through this platform. The other component is, you mentioned subcompartmentalization. The ability to restrict access to only certain things by a certain person or vendor is extremely important in healthcare, and it shuts down the ability to go in the wrong direction, whether intentional or inadvertently. So there's a lot of times where I've seen remote access tools that are intended for access to singular or multiple devices based on a device type and a vendor, but the reality is there's no security controls there, and they could end up on a different system through lateral movement in the network, and sometimes not even know it, but that's where the hackers come in. They're looking for it, and so they're looking for that opportunity to get in and move in any direction they want to, unfettered and traditionally mostly unnoticed, depending on the technology in place for intrusion detection. And it just compounds the problem. So this platform is a step in the right direction to begin to corral those systems, remote access tools, the vendors, to force better relationships and better security controls.
Yeah, one of the things that I like about it is it stands on its own. It's as far as an access manager, but when coupled with the existing XDome Mitigate platform, since we already have visibility on all the devices, we are able to then, for instance, say, okay, you're from Siemens. We are going to give you access to Siemens devices. Boom, it's done, and restrictions are in place. So you're able to come in and integrate in with the existing infrastructure and visibility and functions of the existing platform that XDome Mitigate already provides. So how does that all kind of work with respect to what's Clarity doing to facilitate all of this and align with the HPH CPGs? We'll run through this quickly. Again, the comprehensive asset inventory. We talked about exposure management, network protection. We're able to discern what the communications should be and generate suggested ACLs for, or basically what should be the network segment language code, and pass that off to a network system like Cisco that can very easily implement it, so that you don't have to, that's not a whole manual process. Secure access, we just talked to. Threat detection, being able to identify things and pass alerts and pass them over to a security operations center, fully supportive of MITRE and those type of frameworks, so that you can understand things earlier. And then operational efficiency, we're going to try to talk about that as much as we can. At the end of the presentation, we're a little tight on time, but we're going to do our best to get through there. So when we think about the XDome aligning to the HPH CPGs, there you've got it. You got our broad-based categories and the attack vectors and the essential goals and the enhanced goals. When we lay that out, almost all of them fall within a category. Now, we don't, say for, where is that one? For detect and respond to relevant threats and tactics, techniques, and procedures, that maybe is more of an EDR solution. Well, we can't be an EDR solution, or network segmentation. We're not a network segmentation solution, but we do make those applications much, much better, and the success and the speed of implementation, so that the speed of recognizing your investment in those tools is much faster and much higher. And then others, for instance, asset management, obviously we put that one out of the park, and mitigate no vulnerabilities, put that one out of the park. But so we actually support a myriad of all of these. But so that's really just kind of from a perspective of supporting. But when we think about operationalizing, Skip, can you talk to us about how you operationalized all of these things naturally as a process of putting in your program?
Sure. So the slide, the representation at the bottom, is a representation of a maturity roadmap in an organization. And the overlay above represents the CPGs in their essential and advanced format. And the thing you'll notice here is they don't line up perfectly. And I can tell you that in any cybersecurity journey, there are parallel efforts, there are overlapping efforts, all of which work synergistically for the most part to drive the maturity of a program in terms of getting it operational. The journey begins obviously with the visibility. We're back to CIS control number 1 and moves to the right proceeding in complexity and technical capability, ending in operational efficiency. So the representation here is how might those CPGs overlay in the maturity roadmap of a particular healthcare customer.
And so another perspective here, as you think about it, when you really, if you want to drive down into like what are the mitigation practices that Clarity supports, I'm not going to go through all these, but you can just see that, you know, for the internet-facing vulnerabilities, we're able to identify the internet communications, which ones are connecting to the internet, what are the misconfigurations, insecure protocols, and then for social engineering, we identify weak passwords and what's got weak encryption and who's using outdated encryption certificates. And then the secure access piece, we talked about logs and shadowing and you know, controlling the MDM's access. So there's a whole bunch of mitigation practices that we are actually supporting through that process. So we go into, we got just enough time, I think, to go through the ROI use cases, which is the operational efficiency piece that we haven't talked about yet. And Skip is going to talk about three use cases: fleet utilization, maintenance contracts, and risk reduction as being with Ascension and using the tool. A couple of the ways that he was able to leverage the data. And so, Skip, can you talk to us a little bit about the data, how you got it, and what you did with it?
Yeah, so let's talk a little bit about deep packet inspection first, and that's the capability the platform has, and the parsers have been custom written and built to very specifically identify devices and fingerprint them with no pun intended, clarity to what they are, who they talk to, and where they function within the environment. That is extremely important in terms of talking about the operational efficiencies, because from this data, we're able to glean utilization information. So if you think about a particular modality, an X-ray machine, how often is it used? What hours of the day? What type of images are taken with that device? Where is it within the enterprise, physically and geographically? And that type of information then lends itself to an ability to decide, do we have too many of a particular asset? Infusion pumps being one of those. That's going to be that first use case that we get into a little bit more. And where are they located? And so decisions can be made that actually result in reduced cost, typically in the form of support, as well as the reduction in spend for things like leasing or purchasing more infusion pumps, because the perception is they never have enough. So this is a representation of basic understanding or identification of assets on the network. I often say the wire. And these are MAC addresses and IPs with manufacturing information. The MAC address can usually tell you, based on its format, who it belongs to. But in this view, it's often only looking at the network interface card, the NIC. And everything that's behind that is lost on the organization without the deep packet inspection. So if we move to deep packet inspection and what's revealed to us, we're now looking at different device types by different manufacturers with different versions of software, firmware. We can even correlate FDA recalls to those devices based on the packet inspection and understanding of their function in the environment. And you can see here multiple instances and examples of that. So let's talk about use case, fleet utilization. We, in looking at the scope, obviously, well, not obviously, we looked at all networked medical devices. The question posed was, which of these are underutilized? And in conjunction with clinical engineering, who are out doing preventative maintenance, break fix, and are in the environment and know these things firsthand, and they know the people that use them, you're able to come away with a designation of underutilization through the data, the understanding of people, and then couple that with the risk scoring or identification of CVEs, the KEVs for these devices, and then ultimately can move towards taking action, which can be the removal of the devices, the microsegmentation, but in this case, it was focused on cost reduction. And we were quite successful in using this type of approach and actually removing underutilized, over-provisioned assets. I think we were on a trajectory to save around $25 million in the first year, and the estimate goal for the first year had been $5 million. I think we reached that amount or thereabouts within about 6 months. So for the first time in my cyber career, the coordination with clinical engineering and cyber, as well as clinical apps teams and the clinicians, we produced a return on investment from a security tool. Historically, security is almost always a cost center. It is a form of insurance with no return on investment. And so this is a very dynamic shift in the capability through better intelligence and visibility.
And so let's just make the point here that don't run and tell your CFO that you're going to save them $25 million. Ascension is, extremely large organization, but again, it's all relative. If you could save $1 million, that is more than enough to pay for an entire cybersecurity program, software, and labor for, so your golden child. So it is something that needs to be looked into, and we're actually providing this functionality within our software now because we have this data. So we're generating the reports in the upcoming version of our new releases.
So maintenance contracts, this was a novel idea that one of my close friends and peers leveraged in his organization. And he wanted to know how much support agreements were costing the organization in comparison to their utilization and their risk. So they took a look at those medical devices with support agreements, outsourced support agreements. They looked at and kind of subdivided, low, medium, and high expense, and then further looked into it, subdivided it into the devices that they felt were underutilized. From that, and in coordination again with clinical engineering, because they understand the physical environment and the people within it, so they understand workflows. Workflows don't necessarily come from data assessment or analysis, and that's where that understanding is critical. But at the end of the day, they were able to renegotiate support contracts for assets that they were paying a premium, but they really weren't being utilized that often, meaning their criticality and their uptime was less of a risk to the organization. So back to Ty's comment about impact to the business, that was carefully considered here. And the positive outcome was a reduction in support cost or the opportunity to take support in-house.
We got a couple minutes left here. Can you run through this one for us too, Skip?
Real quick, yeah, risk reduction. So in this particular use case, the question was posed, how many end-of-life and end-of-support medical devices do we have running a particular operating system? And of those, if they were compromised, how many of them would result in extreme harm or death to a patient? So there were thousands of those devices, I think a little over 13,000. And that scope narrowed to 800 that fell into the category of death or harm. And ultimately, through understanding utilization and all of the things discussed previously, 400 or so of those devices were actually able to be retired, outright removed from the environment, reducing cost and reducing risk in collaboration or in conjunction with one another.
Yeah, so I think that kind of it's safe to say that the mandates are coming. The signals are there. Whether they put them in the HIPAA security rule rewrite or they come in a form of legislation from Congress. The White House wants them, HHS wants them. So it's a matter of time. It's going to be include medical devices in all of this. So it's coming to the HTM department in a big way. Within the compliance, it is going to be difficult, but programs like solutions like Clarity's XDome, formerly Mitigate, are right there to help with the compliance, but not only with the compliance, but as you can see, to help pay for the program. So it's, if you want more information, go to the website or reach out to me. I'll get you the right person. Just go to the website, ask somebody to contact you for a demo or more information. We can even provide you estimates on, because those are just 3 use cases. And so you can actually, make a return on investment case for your upgrading your cyber program with a solution that's going to manage all of your unmanaged devices. So with that, Skip, any last comments?
I would just say that if you haven't begun a program, start somewhere. Start with the understanding that you don't know what you don't know, and don't be overwhelmed by the enormity of a particular problem you find. And just know that we're all in it together, which is why I'm always out talking and hoping to pay it forward from my own experience.
And we'd be happy that if you'd reach out to either one of us. And so we'll, I don't know if we got a couple minutes left for questions and in closing it out.
Okay, yeah, we've got a couple of minutes left. So one question that's come in, when will grant money be available and how do I apply?
Okay, good question. Excellent question. Because the process hasn't finished out yet and the money has not been approved, we really don't know. So you're asking the right questions. You're just ahead of the curve. But if you'll go to LinkedIn and follow me, Ty Greenhall, I can assure you that I'll make sure that if it comes up in your LinkedIn feed as to more information about this and how to apply. We will even most likely provide assistance in that as it's going to go to our solutions will be going to support that.
Perfect. So last question is, how will this affect the HIPAA security rule?
Well, the HIPAA security rule has already been decided upon. I mean, that was like 1990s or something like that, right? When this first came out, and hasn't been revised. And that was really more about confidentiality and availability and integrity. Now we're into, patient safety. So it's changed, and the legislation hasn't changed. So HHS has decided they were opening it up this year. It's on their books. By the end of the year, they will have revised the HIPAA security rule. And you're right to question. They are considering adding the HPH CPGs to the HIPAA security rule as a requirement, which would then ground it in legislation. And for those of you policy wonk geeks out there, the Chevron deference that was just approved by the Supreme Court kind of requires that now, that if it's not, any new regulations aren't grounded in existing regulation or existing law, then they can be challenged. And so I think that they're trying to avoid that. I think that's the main delay, that these HPH CPGs aren't mandated already. So it's a good question.
Perfect. Thank you so much, Ty and Skip, for such a great and informative presentation. I'd like to encourage everyone to visit Clarity's website to learn more about the services they provide to the industry. So please visit clarity.com. As promised, the answer to today's trivia question is the Labrador Retriever. So congratulations to our winner, James Whitaker in Texas. So just remember to adopt and not shop. Just a quick reminder, you can obtain your C certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1C credit from the ACI, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@ndpublishing.com. If you've missed any of our past webinars, including any by Clarity, please visit webinarwednesday.live to view our whole webinar archive. We'll be back next week with another webinar, so visit webinarwednesday.live for more details and complimentary registration. So thank you all once again for your time today, and I hope you enjoy the rest of your day.
Thanks, everybody.